Hi, my name is Parker Alligan, and our group's presentation pertains to access to dental care for children in the foster care program. So for our case overview, we have Ella. Ella is a 4-year-old girl in the foster care system with a history of abuse and neglect and a mouthful of cavities who needs general anesthesia for her dental work. She's in her 4th foster home with a new foster parent who has no information about past dental history or records. The only thing that they were told was that they need to get Ella into the dentist within the first 30 days. For Ella's dental procedure to occur, we need 2 things to happen. We need permission for the use of anesthesia from the biological parents, and Ella needs to see a physician beforehand. The foster parent then reaches out to the social worker, which then reaches out to the biological mom and finally gets a hold of her after multiple attempts. And after some convincing, the biological mom okays the procedure. Then Ella comes down with the flu and is going to have to miss her physician's appointment, resulting in her urgent dental appointment being pushed back 4 months. During this time, a new social worker is assigned to Ella, so now the foster parent has to adjust to the new social worker, and during the first conversation, the foster parent seems discouraged and informs the new social worker that Ella has been hurting pets. Fast forward a month, and Ella now has new foster parents, and the new social worker does not have their contact info, which means Ella is likely to miss her appointment.
So from the video, we noted that there were 2 overarching problems that are present in the specific case and the foster care system as a whole. So first off, there's an overall lack of stability for the foster child and the system. There appears to be a constant care team turnover. So in Ella's case, she has a turnover in her social worker and in her foster parents before she even receives treatment for the pressing initial dental healthcare concerns that she presents with. So this lack of stability is a very serious concern as it causes a delay of care for the child, which could be severely detrimental if they have something very serious going on. Secondly, there's poor communication amongst all those that are responsible for the child. There's indirect lines communication and just poor coordination overall. Information flows from the provider or the dentist to the foster parent, who then relays their concerns or needs to the caseworker, who then confers the biological parent. It seems to be like a game of telephone in that information can get mistranslated or left out, which could be damaging. So what compounds this is the lack of centralized healthcare record. So there was no record for Ella going into her new foster home, which made it hard to follow her history and any dental planning that the dentist would like to do or anybody in her care team needs. And so this also delays her healthcare and puts her at even more risk.
Next, we're going to move into some considerations to put this case into a larger context. There were 9 different determinants of oral health identified by Melby in a 2012 study. Some of those that we saw reflected in our case include lack of Medicaid acceptance, lack of systemic record keeping, child transience, and large caseworker workload. Additional research by Melby using 2008 Medicaid enrollment claims in Washington showed that 47% of children in foster care did not access dental care that year, which is a significant underutilization since ideally patients should be seeing the dentist about twice a year. Research from Sarvis that compared children in foster care with their peers showed that children in foster care have a slightly greater than 1.5 times risk of developing oral health problems. On the right here, we have a graphic showing the Medicaid use for oral care in Washington for people under 20 in 2017, broken down by county. And it shows rates ranging from 69% down to about 35%. Taken all together, these considerations show that the systemic challenges faced by children in the foster system are resulting in worse oral health outcomes.
Our group's intervention takes place in 3 phases. And as the first phase of the interventions, our group focused on what the foster agencies can do to solve the problems. First of all, to address the problem of high rates of placement disruption in foster care, the agencies can provide the foster parent with some foster parent skills workshop that are listed on the slide. These interventions are proven to help the children's behavior management and development of secure attachment. Also, studies show that these programs decrease the externalizing and internalizing problems of foster children, which also help decrease the placement disruption rate. Also, prioritizing kin care can be very helpful. Studies show that children placed with relatives are least likely to experience placement instability. So as an intervention, agencies can implement policies that prioritize placement with the kin. Moving on to the next problem, misplaced or lost records of dental history are the norm for the foster children and youth as they move through the foster system. As an intervention, agencies can implement policies that require the storage of dental and medical history of foster children. We understand that these interventions may require federal or state laws to change, but it will be a quick fix to many complications if the agencies can step up and change their own policies.
So to add to what Rebecca was saying, phase one's foster parent skills workshops would include training foster parents before and during fostering a child. This training would include learning methods that foster parents can use to limit disruptive behavior and encourage positive social behavior. There also would be counseling sessions where foster parents, the foster child, and a trained counselor would sit down to discuss the ways to improve the foster care experience for both the foster parents and the foster child. As the intervention grows, we will constantly assess its efficacy and look for ways that we can improve it. We also want to mention that we understand that this intervention will be costly. However, there's plenty of research that shows the effectiveness of similar interventions resulting in better placement retention rates. Placement retention rates are often used as an indicator in studying the efficacy of foster care interventions because there's a lot of data supporting that successful permanent placement correlates with better overall outcomes, and in our interest, oral health outcomes. An extensive study done by Philip Fisher, Bent Burriston, and Catherine Pierce found that a similar intervention had significant impact on increasing successful permanent placements. Our belief is that although the initial cost of implementation may be relatively high, the long term would show its cost effectiveness due to less failed permanent placements and replacements, and also would result in better equipped individuals who grew up in the foster care system being more likely to become productive contributors to society.
Phase 2 is about improving local laws and communication barriers. Poor information exchange can result in adverse health outcomes for children and financial burden for healthcare systems. Tools that improve communication between provider and caseworkers can improve health outcomes and better connect foster children to appropriate services. The electronic health tool consolidated foster children's medical information and streamlined communication between clinicians and social workers. Initial adoption of this tool was promising and better connected foster children to appropriate services. Modifications that can be made to the tool, such as adding alerts, reminders for appointments, streamlining referral requests, can be applied to increase effectiveness of the tool in order to improve health outcomes. According to our research findings, decision-making authority is dictated by court order and seriousness of the decision. Foster parent can make basic decisions, but complex treatment requires a biological parent, regardless of their involvement in the child's life. A medical consenter can be designated to make medical decisions. The consenter requires to verify ability and commitment to the child.
So the first big change that we thought of would be to increase Medicaid reimbursement rates to healthcare professionals, which will ultimately improve access to care for the patients. This is generally done on a state level. So in our case, we saw that once there was a plan of action for Ella, meaning all approvals were complete and appointments with the physician and dentist were scheduled, Ella came down with the flu and her appointment with the dentist was pushed back 4 months due to the lack of availability. And we know that in dentistry, 4 months is a long time, which will lead to a faster caries progression. And therefore, we think that increasing Medicaid reimbursement rates is an excellent solution to promoting more dental clinics to intake Medicaid patients. This will broaden the access to care for patients and improve healthcare outcomes for vulnerable populations. Another big change would be to lobby for universal electronic health records, which would mean that there would be a seamless transition of information between healthcare professionals. This would be done on a national level. In our case, we saw that Ella was in her 4th foster home with new foster parents who had no information about her past dental history, which would include allergies, her dental fears, or her completed treatments. This is a hurdle when planning new treatment plans for Ella. We believe that the universal health record would be exceptionally beneficial to especially foster children who have to go through frequent changes in foster homes and care under different social workers at times. And this centralized record, we believe, would bridge any gaps in communication and provide better health outcomes for all foster children.
Next, we are going to be talking about assurance. We want to follow up to make sure our interventions are working. Our group proposes forming focus groups with phase one, we're going to be looking at stability. We're going to be asking, are our interventions promoting stability? So how long is the foster child staying in a family that has completed the workshops? Are the foster children being reunified when they leave, or are they going to another foster home when they leave? How long is a social worker staying with the same case? If a social worker does change, was there an overlap when they switch caseworkers? Can the foster care agency provide enough information to the healthcare provider? How often are they retaking medical history and looking for consent forms? Did the completion rate of treatment go up? As we move to phase two, we're asking, are our interventions breaking down communication barriers? So how is the provider decision maker communication? Was the provider able to speak directly with the medical decision maker, or is there still barriers to communication? We're also going to be asking about scalability. How does our model, which started from one agency, shift to multiple agencies within the state? And with that, we're going to be asking, can this model shift to a national level? So in phase three, when we reach that national level, we're going to be looking also at our medical reimbursement. Are our medical reimbursement proposals working? How long are patients waiting to be seen after they reschedule an appointment that they missed for whatever the reason they have? How well are our electronic health records working? How often are healthcare providers retaking medical history and looking for consent forms? Did the completion rates of treatment go up nationally?
I will talk about some limitations within our project. When we investigate the problem list, we did literature review to understand those problems with details from scientific approach. However, we noticed that a lot of the research work were conducted at a single facility, which could be a local hospital, a local clinic, or a local foster care medical center. For some studies, they tried to include a certain region, such as a city or a county. Even though they have more coverages, we cannot assume some of the findings and the interventions could be applied to the whole nation. Social workers are usually the targeted population for researchers to investigate this topic. However, there could be a potential source of observer bias since the social workers were responsible for collecting the data. Some data were collected from an academic center outpatient clinic rather than a community-based clinic. So children's health status could be more complex than averages. On the other hand, healthcare providers' input was limited. So we may need more input from them to discuss about the same issue from a different perspectives. We are making interventions based on the limited resource, and the more research and the data could be helpful to determine if all the interventions are applicable for the whole country. Something good to have but hard to achieve is a universal electronic health records, which we agree that could be a huge advancement in serving the foster care children. However, people still have concerns on the data security, maintenance cost, and the lack of national standards.
Okay, so in conclusion, with Ella, who is our foster care child in our case, being involved in the foster care system, she is at risk for a lack of stability within her homes and an increased barriers to receiving care as a result of poor communication and non-centralized information between the healthcare and the foster care systems. We propose 3 potential interventions in a 3-phase approach, with phase 1 being something that's going to be easily attainable, and phase 3 being something that's going to take more time. We're going to see more barriers in order to see success within this phase. So phase 1 is an increase in stability by lowering displacement rates. Phase 2, decrease communication barriers and improve local laws. And phase 3, lobby for legislation change and implement new and more effective systems. And in order to test how effective our interventions are, we're going to create focus groups in order to ensure the interventions are successful.
Here are the resources we use for this project. Any questions for us? We're happy to answer them.